And welcome, Gavin. Thanks so much for joining us. And why don't you start by telling us a little bit about you?
Well, thanks so much. Welcome, everybody. I really appreciate being asked to join this call today with so many interested and dedicated patients, advocates, partners, et cetera. And so I really am honored to be here. So I'm Gavin Clingham. I'm the Director of Public Policy for the Alliance for Patient Access and our Movement Disorders Policy Collaborative. And so MDPC and AfPA are advocacy organizations, and we are based here in Washington, D.C. So I didn't put it in the chat, but I'll tell you where I'm located. I'm in the office in Washington, D.C. I was asked to give a little bit of a presentation here on one of the issues that the Alliance for Patient Access has been following very closely, as I know other advocates have as well, which are some of the recent changes to the Medicare program. And so we've got a little bit of base setting. I know some of this will seem basic for folks. I'll also just say in the advance, no questions are dumb questions, and I guarantee I will be stumped today. This is a confusing change. It's going to take a little bit of time to implement correctly, but the questions will help us get to the right point of giving CMS the information that they need so that they can properly implement this program to the benefit of our seniors and other eligible beneficiaries of the Medicare program. And so if we're comfortable, I'm happy to start through the slide deck. Perfect. And so, Gabby, we can go to slide 2.
Sorry, I'm having some technical.
No worries. Take your time. So what we're asked to talk about today are changes to the Medicare Part D program. And so, but before we did that, we just wanted to level set on the Medicare program at large. And so I think folks understand it well, but let's just talk a little bit about the different parts of Medicare before we move through them. And so what is considered to be called traditional Medicare is the Part A, which is your hospital and inpatient care benefit, and the Part B, which is your doctor's visits and any kind of medication you might get in a physician's office. And so A and B are kind of the ones that when you retire or you become eligible are the ones that you are largely automatically enrolled in. The other two parts, Part C and Part D, we'll do Part D first, are optional. And so Part D is the prescription drug benefit plan. This came into effect well after the Part A and the Part B, and we'll talk about that on the next slide. Part C is what's called Medicare Advantage. And so it kind of combines A and B and D along with some other benefits. And so we're not going to talk about it, but the benefits changes that for the Part B prescription drug plan also apply in the Part C plans. So if you have Medicare Advantage, this information matters to you as well for your prescription drug benefit coverage policies. Maybe we can go next. And so we're going to talk specifically about how did we get to the prescription drug benefit. So this was an add-on to the program. And so sometime in the late 1990s, folks started talking about why do our seniors not have access to coverage for their prescription drugs. And so President Bush, working with Congress, put together a plan for what we call now Medicare Part D, the Medicare prescription drug benefit. It was enacted as part of the Medicare Modernization Act of 2003. And became effective, as you can see here, in 2006. And so while we all take this for granted that we've always had this benefit, really, it's not all that old, right? We're coming up on 20 years of this benefit, but it's a really important benefit. So when they first put this benefit together, it's important to know the deal that was made was that we would offer this to our seniors. The seniors would have to opt in, and they would have to pay for this benefit with some government subsidies. But in return for this, it would be run by private insurance plans. So the government was not going to run this benefit. And the government was prohibited from doing certain things like negotiating drug prices, which we may talk about at the end here just briefly. And so private insurance offers a number of Part D plans that beneficiaries can select from. And so it's important to look through the plan benefits and look through the coverage policies to make sure that what you need specifically, if you're on a Part D medications, is covered here. When it was put into place, it's funded by premium. So the individual pays a certain percentage of premium and the government makes up the difference. They do what would be considered a subsidy. What was a challenge with this, though, was the structure of the benefit really didn't protect seniors in their out-of-pocket expenses. There was no out-of-pocket cap per se. And in addition to being no out-of-pocket cap, along the way, there was a big thing in the middle called the donut hole. And so we'll show a slide in a little bit about who's responsible for what under the new plan. But, the beneficiary has a certain upfront cost that they need to pay, a certain out-of-pocket they need to pay. This upcoming year, it's going to be around $590 is the exposure that they have at first. In the old plan, you would go into what was called the donut hole in between there. You would get a whole portion of it where you were very exposed to the expense of your medications before the coverage kicked back in. And so it's very expensive for the seniors. And so a number of years ago, they started trying to reform this. And so starting in 2010 through the Affordable Care Act, they began trying to get rid of this coverage gap in the middle. And so they made tweaks and changes. And so it was beginning to help. But it wasn't getting all the way there. We still had a lot of exposure. It was also the only prescription drug coverage plan that did not have a out-of-cap limit. So you could be exposed all the way through whatever dollar number there was. And so, Gabby, we can go to the next one here. So the Inflation Reduction Act, which is what we're going to talk about today, which was passed in 2022, has made very significant changes to the Part D prescription drug benefit program. The big ones are listed right here. It's a $2,000 cap. So the most that any beneficiary will pay is $2,000 for their for their pharmacy benefits, and then you have the opportunity to smooth out or pay in monthly installments that $2,000 expense if you're in that category of having that expense. And so two big changes. We'll walk through those as we go through this deck here. So as I said, the Inflation Reduction Act was signed into law on August 16, 2022. And so they're making progress quite quickly in implementation here. And so there are three big parts of it. We're really going to focus on the Part D restructure, but there were big three changes that came in here. One had to do with this, what we're going to talk about, the restructuring of the benefits. So what our seniors and other beneficiaries face, what costs they face. It gave CMS for the first time the ability to negotiate drug prices. As I said before, the deal to get this enacted into law was the private market will take care of this. The private sector will take care of this. Government will stay out of this. Well, that deal was changed in 2022. And the reason I flag it here is because the medicines that they're able to negotiate currently are within the Part D program. And so they may have implications on what you're able to access and what the costs are. And then finally, it included an inflation rebate. So if manufacturer prices rose faster than the rate of inflation, they had to rebate some of that funding back to the federal government, only in the Medicare program. Last quarter, 64 medications fell into this rebate provision and had to send money back to the government as they changed the prices of their medications. So the first year that this went into place was 2024. So in the current year that we're in now, there have already been changes to this plan. And so they're gradually moving towards the big changes that come in 2025. And so here's what happened this year, right? This is what happened. So they got rid of cost sharing in the catastrophic phase. So anything over $7,000, which is considered where they put the catastrophic phase limit, I'm sure much lower is catastrophic, but $7,000 was what the limit was, would no longer cost the patient any more money. There would be no more copayment. It used to be 5%. That was eliminated. So that's already gone. They put a cap in on premium increases. And so the premium increase to the beneficiary of 6%. So it cannot move up more than 6% to the beneficiary year over year. And then they made zero cost sharing for vaccines. So they kind of extended a COVID era policy there, but they wanted to make sure that our beneficiaries could access their vaccines at no cost themselves. Preventative medication is extremely important. And it expanded the low income subsidy program from 133% of federal poverty limit to 150%. So the subsidies increased from more beneficiaries, more individuals were able to get those subsidies. So that's already in place moving forward. What comes next is the 2025. And this is really what we need to talk about and what people need to be aware of, because it puts a lot on the Medicare patient, the Medicare beneficiary to make decisions here. So very exciting, right? It's going to cap the out-of-pocket expenses at $2,000 per year. Now, not every beneficiary hits that cap, right? So that cap is important, but it's not going to benefit everybody. It establishes the prescription payment plan, which is what we refer to in the advocacy community, the smoothing mechanism. But it's the way to set your payments at an even level at each month, so you can know what you won't pay more than. Right, each month will vary depending on new medications or when you started the medication throughout the year. But you know that you won't pay more than, I believe the answer is $166, 1/12 of $2,000. It got rid of the coverage gap, so the donut hole is now gone. So that's amazing and great. So people don't face huge bills in the middle of the year and have to decide between paying for certain things or dropping their medications. And then it requires manufacturers, and we'll see on the next slide where they shift all this money around. It requires manufacturers to provide a discount of 20% during the catastrophic phase. So they're trying to hold costs down, and they're trying to make manufacturers and insurers more liable for the out expenses. So this is the out-of-pocket cap here. This chart here is a little small, but hopefully people can see it. We're trying to explain it. And the part of this that matters most to us is this part here, the dark blue. And so that's the enrollee, and that's the enrollee exposure. So if you look on each chart, there becomes a little less dark blue and a lot more brown or tan or gold or whatever that color is, and a lot more light blue. And so dark blue is what we would pay, right? That's the enrollee exposure. So in 2023, 100% of the deductible, that remains the same. That's still our exposure. In the initial coverage phase, we are now responsible for 25%, with the remainder being split between the insurer plan and the drug manufacturer. As you move up, this government steps back in for some of it, but a lot less than the government was paying. And so this will matter, when we talk about consequences of this. Government was trying to bring down their costs, but they've shifted the costs off of the beneficiary, and they're trying to shift it off the government, and they're shifting it onto the health insurer, so the private insurance plan who's providing this benefit, and the drug manufacturers. And so when you look a little bit on the left-hand side, so the Part D will be capped at 2,000. Roughly 1.4 million people are expected to save $1,100 on average from what they were spending. So significant savings for a significant portion of population and beneficiaries. But there are concerns over increasing the difficulty for Part D plans to participate, right? As you continue to bring down what they're receiving, they're going to have to raise premiums, but we've told them they can't. And so somehow we've got to reconcile what we're doing here. The costs haven't gotten any lower. We're just switching around who's responsible for the costs. Next slide, please. So these are some of the key deadlines. This is the 2024 calendar deadline. The reason this is so important that we're doing this here in September is that open enrollment period, October 15th through December 17th. But so you can see here, the Part 2 guidance telling how they're going to implement this program was released in the middle of summertime. And so that's what we've been kind of combing through, trying to understand. I see a note down there that says some folks can't see the slides. I can see them. Are others having trouble?
We can see them. We'll send a note to
Okay.
Sue to change the view, but
Sorry, I didn't want to like go too far if we weren't seeing them. But so thank you. And so then they've released the negotiated drug prices. That's the maximum fair price there. That will matter later in our conversation. Plan Finder is going live October 1st. And so this is when folks can look at their plans and see if they cover the medications that they need, or how's it going to work for us. And then the open enrollment plan, open enrollment period is October 15th, starts October 15th. So we're going to be making these decisions in the relatively near term. And so for a redesign that goes live January 1. And so it's real time now. It's go time now. And so that's why we're very excited to be here to join, because this is something that's new to folks, and it's going to take a while for people to understand. And we want people to be able to ask questions like we talked about and really see what it is that they need to be doing to make sure that they're getting the best coverage they can. So part of this challenge here is there's a lot of responsibility on the beneficiary. And so the $2,000 cap applies to everybody who's in the program, every Part D beneficiary, but the smoothing mechanism or the prescription payment plan does not. So individuals have to decide, is it a benefit to them? If it is a benefit to them, they have to then opt into the program, and then they have to follow the rules of the program. And so there are changes that are coming to the program that will all entail. And so CMS knows this, and the advocacy community knows this. And so this slide here outlines who's required to and who's trying to get the information to the beneficiaries. And so Part D plans are going to be required to provide information to enrollees. So they're going to have to mail information or email information. So your current plan and other plans are going to have to provide information about this option and how it's going to work for them. They must they must provide a notice of those who they think are likely to benefit, right? Not everybody's going to benefit from this, but many are likely to benefit from this. And so that's a complicated formula on how they're going to decide who's likely to benefit. I think it's, people who are, or who have they have high spend are likely to benefit. I think CMS has picked a number of $600 as $600 in a monthly, and one monthly would be likely to benefit, but not everybody should opt into this. And so there's going to be a decision-making process. And we'll talk a little bit about that more towards the end. CMS is developing a model enrollment form. So that should make it easier for everybody to enroll the information that they believe is necessary. And Part D sponsors will use that model form. CMS is going to provide education on Medicare.gov. So there will be resources that CMS is producing. CMS is going to apply the changes in their plans before the plan year begins. So we should have an opportunity to see all that. And they've already released some of it. And then they're going to ask pharmacies to help out. And so pharmacies are going to be required to hand out, likely to benefit notices. So when they have an individual who comes up, they're going to be giving them information. And all that being said, we have to receive the information. And so advocacy organizations like the Alliance for Patient Access and others are working really hard to inform people about the changes that are coming and the responsibilities that they have. Okay, we go to the next slide. And so this is the first of one advocacy tool that the Alliance for Patient Access has produced. This is just an explainer. It's a patient's guide. So what is the Medicare Prescription Payment Plan, and what does it mean for you? And we'll drop a link to this into the chat here so that folks can have it. As with all Alliance for Patient Access materials, they're on our website, downloadable. Anybody can use them. Please feel free to share them. We will be producing a video, and we'll be producing more materials as we get a little further into the year. But this is kind of our first cut at something that's simple, understandable, and actionable in explaining what this plan is and how it can benefit our seniors and other beneficiaries. Next slide. So who should opt in, right? This is where it gets confusing. It's open to all Part D enrollees, so anybody can opt in, but only those who incur high out-of-pocket expenses early in the year are likely to benefit the most. And so that's just kind of an assessment. And we all know that our medications change throughout the year. We may not start in January, and may not start something until later in the year. And so it's going to be a bit confusing, a bit bumpy, but really it's kind of a gut check on how high expenses are. So they should be based off the monthly and annual out-of-pocket costs for previous years. So we have to look backwards and say, how much this has cost us in the past? Is it more than $2,000? We probably want to opt in on this. And then, if your out-of-pocket are $2,000 in the first 3 quarters, you certainly should opt in. And so these are just kind of guides, and we'll drop a resource towards the end. CMS has a tool that they put together. I've not spent a ton of time with it, but it asks some simple questions about whether or not you think that you should be opting into the program. So when we talk about unintended consequences, this is one of the unintended consequences. So they've been capped at how much they can raise the premium. You'll see in the middle there, the base beneficiary premium is going to be up 6%. So it's going to be up to $36.78 per month. And so that's that represents the maximum growth that it can be increased annually. So all insurers said we're going to go to the maximum, but that's the average base price. So it will differ for others. But if you look to the left, when plan sponsors went to the federal government and gave their bids, those bids are up significantly. So those bids have been $64 in 2024. They're $180. And so the cost shift away from patients and the government onto the insurer has led them to say, well, we're going to need a lot more in base premium support. And that's the responsibility of the government. But I want to flag that that's out there because it's causing concern with the program. And, any new program that comes in, year one is always rocky, right? If folks remember the Affordable Care Act rollout, Obamacare and the exchange plans, year one was incredibly rocky, but they knew they had to get started going. And, by year 2 or 3, it was running relatively smoothly. I wouldn't be surprised if we saw some bumps in the road on this. But that being said, because of the left and the large increase in what there is, and because of kind of the differing increases depending on where you are, I think it was great that we put where we are across the country, because different premiums are very different in different parts of the country. So CMS has announced a voluntary demonstration program for the insurers to help level out this risk that they face now, and they've encouraged them to enroll in this. And I just flagged this as an unintended consequences. Anytime you make a major change, you don't know what's going to happen, and so this has kind of been the reaction of the plans, and this is the reaction of the government to try to make sure that we maintain a robust network of coverage. Next slide. And so this is just the takeaways from the demonstration program. It's a voluntary program for insurers. It's nationwide. It reduces the base beneficiary premium by $15 in exchange for some money on the other end. And so that might be a benefit to folks. And it's designed for 1 year and could be extended. So what this tells us is they don't know how much they need this. They don't know how much stabilization this is going to need, but they want to have the flexibility to make sure that they do. Next slide, Gavin. So this is kind of the last slide I've got here before we go to questions. This is kind of key takeaways of what do enrollees need to know. So the prescription prescription drug benefit redesign goes into effect January of 2025. This will in fact happen. So starting in January, there will be a $2,000 annual cap, and there will be access to what they call the Medicare Prescription Payment Plan, MP3. We call it smoothing. Think of it as your electric bill, your heating bill, where they offer you the option to spread it out over 12 months rather than having a very high heating bill in the winter and a very low heating bill in the summer. They give you the flexibility to spread it out, hoping that it can help people cover their costs and remain adherent. We need to know that it's an opt-in. We are not going to be automatically enrolled in this. We need to take an affirmative action to opt into this program. It's also not for everyone, right? We may or may not benefit from it, so we need to take the step to try to understand whether or not this is right for us and will help us with our payments. This is one's really interesting or important. It's going to be a new payment structure. So beneficiaries will no longer pay at the pharmacy. They will go to the pharmacy and they will be able to get their medications, but they will not be charged a copay or a coinsurance at the pharmacy. They are now going to be sent a bill by their health provider, by their insurance provider. And so this is going to be one of the biggest changes and mental barriers that we're going to have to overcome. We're going to be paying differently, but it doesn't mean we don't owe them money. And so instead of handing over money straight to the pharmacist when we get our medications, knowing that we're going towards our out-of-pocket and we're meeting our stuff, we have to wait till we get a bill from our Part D plan telling us what we owe for that month. They will do the calculations. That's their requirement. If we're opted in, they'll do the calculations. But we need to make sure we pay that bill, because the penalty for not paying that bill is exclusion from the program. And so if you don't pay, you'll be I don't know if it's 60 days or 90 days, but you'll be removed from the program. And so it's unclear when you get back in the program or not. And so if you're benefiting from the smoothing mechanism, you want to make sure that you're paying attention to the fact that you're getting billed now, paper bill or an electronic bill that must be paid to your Part D plan. This one here, we have it written really simply: enroll on the Medicare website. There's a lot of fraud in the Medicare program, and a lot of fraudsters, not in the program, there's a lot of fraudsters around the program. And it's really important that we not sign up in an inappropriate place. We do not want to be giving our money or sending any of our stuff or even our information to anybody who's not the correct place. So the place to enroll is in the Medicare website. So we want to be really careful that we're following that properly. Where can you get the information? CMS is going to provide the information. Your insurance provider is required to provide it. Your healthcare provider will have some information on it. Patient advocacy organizations are working at breakneck speed to try to get information out there for folks so that they have it for their patient population. And your pharmacist is going to provide this. So hopefully there will be enough information out there. Hopefully it will be in a digestible manner. But we think this kind of hit list here are kind of the top things you need to know. It is happening. You may benefit from opting into the prescription payment plan, but you have to opt in. Payment structure will change where you're going to be billed as opposed to paying at the pharmacy. So you have to note that, and you have to make sure that you enroll in the proper place. And so I can pause there. That's our last slide other than questions, and we can take the deck down and have an open conversation. I'm sure there's lots of questions we don't know, but I'm happy to try to help and really appreciate the opportunity to present today.
Yeah. Actually, before you take, well, if a question refers to a slide, we could bring it back up. So again, $2,000 total, not per drug, right, Gavin?
$2,000 total, not per drug.
Okay. And anyone can opt in.
Yep. Anybody can opt in, but nobody will be automatically enrolled.
Got it.
So this is
And,
on us to make the decision.
okay. If you don't opt in during open enrollment period, can you change your mind? Or if you do opt in, can you change your mind?
I know the answer to the first one. I'm not sure about the second. You can opt in at any time during the year. So if you have changed circumstances that you get a new prescription that comes into your treatment plan, you can opt in for sure. I would assume the same as the other way, but I'm not exactly sure.
Okay. So if you go to your neurologist appointment in March and they want to put you on a new drug and now it's more expensive, you could opt in at any time throughout 2025.
Yep.
Okay.
And there are payment calculators that go to heart how all of that works. They're quite confusing at present, but I think that they'll get simplified as soon as we have more experience with people enrolling at different points of time with different price points and different medications.
Okay. Got it. And someone asked this question. I thought it was good. I take the same drugs every month, same price every month. I don't understand the concept of smoothing if I have the same drug costs every month.
So that's a great question. And I think in that way, you're already in smoothing. But it also means that your medications aren't hitting at the point where this is price prohibitive for you unless unless your monthly is more than $166 a month. And so, I think you just need to watch that. But this also permits for change in medications or change in strengths or change in different things here. And so, the smoothing mechanism is for folks who have high out-of-pocket expenses. So if you've got a medication that has a co-insurance, for example, and you might have a $1,000 bill or a $600 bill in the first month of the year as you take that medication, well, you're going to have to hit your out-of-pocket, right? So you've got your $590 out-of-pocket that you pay first before coverage kicks in. And so it's for folks who have the high medications that hit into there or heavy medication use that will want to consider this plan.
Got it. Okay, let me scroll through some more. Nadine wanted to know if you do not opt in, do you still pay at the pharmacy like you do now?
I think yes, but I'm not positive. We're going to have to come back on that answer.
Okay. And okay, we have some analytical questions about what this means for the future, but let me make sure I'm covering some of those like foundational questions. Let's see. Okay, I think we covered all of the. So once you opt in, does that decision need to be updated every year at open enrollment?
I believe it needs to be updated every year, and open enrollment would be the appropriate place to do so.
Got it. And then next up, we have what impact does formulary have with this? Will expensive drugs be removed from the formularies? So could you also, for a refresher, explain what a formulary is for all of us?
Yep, absolutely. So a formulary is the drug list that you're allowed to access. Every medical benefit and every pharmacy benefit has what's called the formulary, and formularies are set out into tiers. And so, tier one drug would typically be a generic medication, something very low cost and widely available. Tier two becomes probably a brand name small molecule medication, but a preferred one. Tier three becomes more into the specialty medications. Tier four, even more into the higher price specialty medications. So think biologics and the like, some of the more expensive medications. The more expensive list price medication, the more likely it is to be on a higher tier of the formulary. The challenge of the formulary tiers for patients is each one comes with a cost sharing aspect to it. And so the lower the formulary tier, the more likely it is to be a co-payment. So that's a set dollar number that you're obligated in order to get your medication. Think maybe a $5 or a $10 co-payment for a generic medication. As you move over into the specialty tiers, the higher tiers for the more expensive medications, those tend to have a co-insurance aspect to them. So a percentage of the list price of the medication. And so this is why it's so challenging and why these medications are so expensive to the patients who need them and rely upon them. And so formulary design is critically important in determining what medications we access and can afford, quite frankly. And so the question I believe was, do we expect to see formulary changes, or do we expect to see, changes as a result of this? And so the answer is yes, I do. And I think we all do. And the question is, what does CMS do to police this, right? And so CMS does not want to see these negative changes, but we know that cost pressure and profit pressure will cause pharmacy benefit managers and the pharmacy insurers to look at these processes and see what they can do in order to either steer certain ways or do better cost share or make sure that they're maximizing their costs. And it won't only be for folks who are high users who are going to hit the $2,000 out of cap, right? Are they going to be able to shift cost to other people and bring people closer to that $2,000 cap, right? And so CMS is requiring that plans provide information about this. That's as far as they've gone to date. So they've not said, we're not going to allow you to change the cost, the copay. They've not said, we're not going to allow you to change tiers. They're saying, you're going to have to tell us what you're doing and why you're doing it. It's a difficult one. It hasn't happened yet, right? So it's hard to tell them what the consequences of acting or not acting are, because this won't go into place until 2025. But we'll start to see the formulary designs sooner than that, right? They'll come out before open enrollment and during open enrollment, so we can look at those. And I think we all need to be diligent about that and sharing stories about, hey, my medication was moved from this to this, or the cost of it was from this to this. And so I don't think we know what the consequences are, but I think we can anticipate that there will be consequences. And so we're watching it, others are watching it, CMS is watching it. But it will be tricky for a little bit to make sure that we're still maintaining strong access.
Okay. One more down the road consequences question. Could this affect innovation and new drugs, pharmaceutical companies researching new drugs? Might they invest in younger populations, not people typically on Medicare?
That's a great question. So when the Inflation Reduction Act was put into place, one of the concerns expressed about it, particularly around the drug price negotiation portion of it, but also around the Part D restructure, is what will it do for innovation? What will it do for investment? It's easier to explain the consequences on investment with the prescription drug negotiation, because chemical drugs, have a 7-year exemption before they can be negotiated, where biologics have an 11-year. So it's easy to say, well, the manufacturer is going to go for a biologic. They're not going to invest in small molecule medications. And so that one's a little bit easier to understand. Again, all of this remains a little speculative, right? It's all in front of us still. We haven't really gotten to the meat of it. And so we're hopeful, no. We're hopeful that the manufacturers maintain sufficient incentives. But also, we think that for this part of it, we're much more concerned with the impact on the insurer behavior than we are in the innovator behavior. We think they'll continue to innovate, but we're concerned that we'll lose access to certain therapies. Or either they'll be removed from formulary or they'll be priced out of formulary for financial reasons that are being impacted by the redesign.
And since everyone watching here is part of the PMD Alliance community, also want to commit, we have our ears and eyes open as well. So if a drug that you're on, if there's formulary changes, send that to us, and we work closely with AfPA. So we are on the lookout for all of you and can help prevent address some of the unintended consequences, or have eyes on them.
I think that's really important, and thank you for that. The hardest part of payer advocacy is finding the example. It's happening, you think it's happening, but everybody's kind of fighting for their own access. And so where you can share those stories more broadly, it's very valuable.
And someone said in the chat that those insurance companies make a ton of money. So yes, you have to advocate for your needs, for your family, for, your finances. So lots of folks out, lots of organizations out here. So, okay, some more kind of foundational questions have popped up. So let's rewind to make sure we understand. Um, so let's see. If a person opts out, does that mean they have no prescription drug coverage? So maybe kind of rehashing the opt-in status quo,
Yep. So,
what that
yep.
means.
Perfect. Thank you for that. Great question and really important to clarify. And so everybody who's in the Part D program remains in the Part D program. So you have to first you have to join the Part D program, right? So we're enrolled in the Part D program, and then everybody who's enrolled in the program gets the benefit of the $2,000 out-of-pocket cap. So there's no action needing to be taken to be part of that improvement to the program. The only thing that you would opt into, and so there's not even an opt out. The only thing that you would opt into is whether you want to balance your payments month to month. And so no one has opted out of anything. If we're in Part D, we stay in Part D. If we're in Part D, we get the benefit of the $2,000 out-of-pocket cap. If we're not in the smoothing program, the prescription payment program, we may have a big monthly bill, but we still have access to our medications. We still have access to our Part D plan. And so the only thing that really is opt-in is whether or not you want to spread the payments across the months.
Thank you. Okay, and someone took my advice and wants to apply it to their specific situation. So they said they're currently on a $1,000 drug that earlier this year had a copay of $46. They're now in the donut hole and paying $251 per month. So if they were to opt in with this scenario, how would their costs change?
That's a good one. I can't run the calculator on that one, but it seems like that's like somebody who really does need to investigate whether it makes sense for them. And so I don't know if we dropped in the chat yet. We'll drop in there a link to the CMS materials that are brand new, maybe came out as recently as yesterday or the day before. There is a questionnaire in there that says, should I opt in? And there are a couple of places where they give examples of folks who should opt in. And so I think that that's a really good one to run through the calculator. There will be other calculators, but I think that that's the kind of person who really should be considering this program. It sounds like that kind of a cost would be beneficial to be part of it.
And yes, we can grab that link and oh, wow, magic. There it is. Okay, another question, or this is a comment. Dave says, during open enrollment, you should consider a Part C or Medicare Advantage plan. Like, should you think differently about choosing a Medicare Advantage plan given this new Part D option?
That's a great question. I'm not going to give insurance advice. I will say that this smoothing plan that we're talking about, this $2,000 cap, and this prescription payment plan also applies in the Medicare Advantage programs. So for your pharmacy benefit there. Now, where they have additional flexibility would be able to move medications between the Part D and the Part B benefit. And so because they're all one kind of a plan. But all the information we've been talking about the $2,000 cap applies in Medicare Advantage. The requirement that they offer a ability to do a prescription payment plan also applies there.
Okay, and there were two questions about whether Part D or Medicare Advantage is done through private insurers. They have Humana and they're on Medicare. That again, we don't know your exact situation, but we can say that yes, it is Part D is administered by private insurers, right?
Yes, Part D is administered by private insurers, as is Medicare Advantage.
Okay. Let's see. Oh, someone asked earlier, you said the $590 annual deductible. Can you re-explain what that is?
Sure. So that's the first part of what the patient is responsible for. And so in previous years, it was much more significant, but the patient is before any of the other payers come into the pay, the patient is responsible for the first $590 of out-of-pocket costs towards their medications. And so that's what that dollar number is. It's up $45 from this previous year. But remember, that goes towards the $2,000 out-of-pocket cap. And so that is considered in that same space. And so while that's a significant number, it is still counted into the $2,000 out-of-pocket cap.
Okay, that was my next question from Dennis. So thank you for that. Next up, someone wants to know if this is at risk of being completely changed or removed by the next presidential administration.
So this was passed into law. So Congress acted and they put this into place, and it was signed into law by President Biden. So to undo this would require another congressional action. And so I think it's unlikely, but not impossible, that this could be changed. I think, if we followed healthcare policy debate in Washington, D.C. for any amount of time, we know that when the Affordable Care Act came into place, it took a long time to get it into place. Once it was in place, opponents of it voted multiple hundreds of times trying to get it out of place and lost each time. I think that you would find a popular benefit like this difficult to undo. Doesn't mean it couldn't be, it doesn't mean there couldn't be some challenges, but I think you'd find it very difficult to be undone. But it certainly could be done, but it would have to be done legislatively. An act of Congress would have to be passed and signed into law by the next president.
Thank you. That's a great answer. I thought you were going to say you don't have a crystal ball, but that actually is helpful to know what would be entailed if a change were to be made. Okay, let's see. So, oh, this is a good one. Someone wondered if, and maybe we can screen share the slides, get that conclusion slide, the last one, because we kind of went all over the place with some of these individual questions, but I want to make sure people are left with the take home, what do I do? What are the important dates? And great to wonder about, unintended consequences and what could change and what happened, but let's recenter in on these key takeaways. So could you present this slide again, Gavin?
Yep, absolutely. So key dates, October 15th when open enrollment starts. So that's the key date for all of us now. We have to pick a new plan or stay in the same plan. That's open, I think, until December 17th. So that's not on this slide, but I wanted what the most important date is that window there where we choose our plan. And so what we all need to keep in our mind as we're doing this is if we're in the prescription Part D prescription drug plan, as of January 2025, for the calendar year 2025, there will be a $2,000 cap on our prescription drug co-payment out-of-pocket expenses. And so that's for everybody who's in the program. And so that's a huge improvement. Not everybody benefits from it, though. That's what we're going to talk about next. Not everybody hits that cap, or not everybody exceeds that cap. And so for folks who do exceed it, though, they should know that there's the prescription payment plan. So we always called it smoothing, right? You're just kind of going to flatten it out across the year. CMS didn't like that terminology for whatever reason, so they came up with Medicare Prescription Payment Plan. MP3 is the short name for that. And so that is the one where you can opt in, right? So if you have a high spend, you will opt into that program. You will not be automatically enrolled. So that's the other key factor, is that you have to make an active decision that this will benefit you and you want to participate in it. What the change will mean is this new payment structure. You will no longer pay at the pharmacy as you have historically. You will get billed by your insurance plan, and you will pay your insurance plan directly. So the insurance plan is going to settle up on your behalf with the pharmacy, and they're going to settle up with the other participants in the government and the manufacturer. But for you, the change is that you will get a bill. And so you have to be watching for that bill to make sure that you pay that bill. The penalty for payment lapse is that you could be excluded from the program. They could tell you that you're not going to be allowed to participate in not the Part D program, just in the payment plan part of the program. And then make sure we don't enroll in the wrong place. We have to protect ourselves, so we want to make sure that it's Medicare that we're enrolling in. And then where can we get our information? CMS, so the Center for Medicare and Medicaid Services has a lot. The link, Gabby dropped the link into the chat for everybody. The insurance provider is required to give you information about this option that you might want to consider it. And they're supposed to tell you if you're likely to benefit. So that should help us decide whether or not we want to participate. Your healthcare provider will probably know something about it. We've been talking to a lot of them at the Alliance for Patient Access. They're learning about it, but they may know something about it. And then patient advocacy organizations, your organization, our organization, other organizations are ringing the bell and trying to alert people to this change. The good part, the cap, the questionable, the questionable benefit, should you opt in? And then what happens if you do opt in? Make sure you stay in.
Thank you. And I'm going to screen share that website that you mentioned that we put into the chat, so you can see what the tools are, what you want to do, and will this payment option help me answer those questions, run through, know what your current situation is. You can, plug in what you're currently doing and can guide. Again, haven't done this, so would be curious, for those who use this and find it helpful or not helpful, please do let us know, but can run through some scenarios to figure out whether you want to opt in or not. And then again, from Medicare, the trusted source, like that slide that Gavin just went over, what to know if you do participate, so you don't, that sounds like a terrible thing. What if you get confused and you don't pay, and then it lapses? That's terrible. So definitely want to make sure you're not paying at the CVS or Walgreens counter anymore, but you still have to pay. And just be able to walk through some of the resources, see a little video there, and we can put that link in the chat again. Okay, great. They already are. That's magic. So thank you, Gavin. This was a lot, and I'm glad that we have recorded it, and we will have the slides and the links on our website. Give us a day or two to get that up. And we want, this is something that I think you're going to have to refer back to. And if doing that, if you have questions, please do send those to PMD Alliance. We can synthesize those and get you the answers. So any closing words before we say farewell to everyone, Gavin?
I would just thank everybody for joining today. I know you're an active community. I knew that before I came on the call, so I appreciate all the questions and the interest. This is exciting stuff. I think it's important stuff, but there's a lot there, as was said, and so appreciate being included.
All right, thanks. Well, we invite everyone to close with a wave of gratitude. So if you're not in your undies, turn your camera on. And thank you, Gavin. Thank you, Gabby. Thanks everyone for putting this together. And we'll navigate Medicare together. Bye now.
Thank you.